A 54-year-old man rolls into your emergency department. He's gasping, diaphoretic. His respiratory rate, 35. He's on a non-rebreather, but his oxygen saturation is still 82%. He's using accessory muscles, and now he's starting to lose consciousness. You know what comes next. You're going to intubate. But before you hit that vent switch, let's talk about what actually matters. Because mechanical ventilation isn't just about pressing buttons. It's about physiology and anticipating what the body's going to do next. Let's break it down, step by step. Step 1. Understand why you're ventilating. Most people think, oh, he's hypoxic. Slap him on the vent. But that's only part of the picture. We ventilate for 5 big reasons. 1. To fix oxygenation issues like hypoxemia. 2. To offload carbon dioxide, especially in hypercapnic states. 3. To reduce the work of breathing when the patient is just too exhausted. 4. To protect the airway. Think trauma, overdose, or seizures. And 5. To give the lungs time to rest and recover. You need to know which reason applies, because that shapes how you set the vent. Step 2. Check the indications and know the traps. When do you intubate? Classic indications include type 1 respiratory failure. That's low oxygen, like in ARDS or pneumonia. Type 2. High carbon dioxide, like in COPD or opioid overdose. Apnea, inability to protect the airway, or full cardiac arrest. But here's where people get into trouble. Not because they intubated, but because they forgot how the body might respond to positive pressure. For example, if someone's in severe metabolic acidosis, like in DKA, they're blowing off CO2 as fast as they can. You put them on a vent with a fixed rate, you might trap CO2 and crash their pH. Same with someone who's hypovolemic or in right heart failure. Positive pressure drops preload, and suddenly they code. And if there's a pneumothorax, you better decompress first, or the vent will turn it into a tension pneumo. Step 3. Setting up the vent. Okay, so you've intubated. Now you're staring at the vent. What mode do you choose? Go with volume assist control. That's AC/VC. It's reliable and it works for most emergencies. Now let's talk numbers and why they matter. Start with tidal volume. Aim for 6 milliliters per kilogram of predicted body weight. This protects the lungs, especially in ARDS or acute lung injury. Next, respiratory rate. 16 to 22 is your sweet spot. Go higher if your patient's hypercapnic. FiO2. Always start at 100%, but don't leave it there. Titrate down quickly to avoid oxygen toxicity. PEEP. That's positive end expiratory pressure. Start at 5, maybe go to 10. It helps keep the alveoli open, especially in conditions like pneumonia or pulmonary edema. Keep your plateau pressure under 30 to avoid barotrauma. And your inspiratory to expiratory ratio, start at 1 to 2. For asthma or COPD, give them more time to breathe out. Use a ratio of 1 to 4. Step 4, don't just walk away. After about 20 to 30 minutes, check an ABG. That tells you how well you're ventilating and oxygenating. Also look at end-tidal CO2 and match it to the arterial PaCO2. Now what if your patient suddenly drops? Run through DOPE, displacement of the tube. Honey, obstruction, like mucus plugging or biting the tube. P, pneumothorax, ounce equipment failure. Always have that checklist in your head. Step 5, sedation and pain control. If you used a paralytic, like rocuronium, your patient can't move, but they can still feel everything. That's why sedation is not optional. It's essential. Good choices? Propofol, easy to titrate. Just watch for hypotension. Dexmedetomidine, great for keeping them calm without dropping blood pressure. Benzos, used sparingly, especially in the elderly. And don't forget pain control. Fentanyl works fast, 1 to 2 micrograms per kilogram. You can also use morphine or hydromorphone. Target a sedation score, like RASS, between 0 and -2. Calm but not snowed. Step 6, weaning and extubation. Let's say your patient is waking up, and their oxygen looks good. Do you need to keep them intubated? Not always. If the cause was reversible, like an opioid overdose or a seizure, you might be able to extubate in the emergency department. Here's your checklist. Switch to pressure support mode. PEEP at 5. FiO2 at or below 30%. Then calculate the rapid shallow breathing index. That's respiratory rate divided by tidal volume in liters. If it's under 105, extubation might be safe. Also, do a cuff leak test. If there's no leak, that airway might still be swollen, and extubation could fail. Final thoughts. Mechanical ventilation isn't just about hitting on. It's about understanding the physiology behind every number and staying ahead of the curve. So next time you tube someone in the ED, ask yourself, why am I ventilating? What's this patient's physiology? And what can I do right now to keep them from crashing? Master that, and you won't just survive your next airway case, you'll lead it.